welcome to our first of the MOGCast series entitled MOG-AD Diagnosis, Testing, and Titers. Today we are speaking with Dr. Owen Flanagan and Dr. Chen from the Mayo Clinic. My name is Julia Leffler, Executive Director and co-founder of the MOG Project. The MOG Project is a US-based nonprofit organization devoted to raising awareness, advancing research, and providing support and advocacy for the MOG-AD community in hopes of finding a cure. We would like to thank the doctors and the MOG Project members for their contributions to this podcast. I am here with Andrea and James Mitchell, who will be co-moderating this MOGcast with me. Andrea and James?
Hi, my name is Andrea Mitchell, Executive Board Member and Director of Blind Resources for the MOG Project, and I'm here today with my husband, James.
I'm James Mitchell. I'm her husband, caregiver, and best friend.
This MOGcast is being recorded and will be available on our website, Facebook page, and YouTube channel. If you want to submit questions, please feel free to do so by commenting on our Facebook Live video.
We will be answering community questions today, and any leftover questions will be placed on our MOG blog, so stay tuned.
Okay, Dr. Owen Flanagan is a professor of neurology and consultant at the Department of Neurology and Laboratory Medicine and Pathology at Mayo Clinic in Rochester, Minnesota. He did medical school at University College in Dublin in Ireland in 2005 and later pursued neurology residency and neuroimmunology fellowship at Mayo Clinic. He received a master's degree in clinical and translational science at Mayo Clinic, is principal investigator on an NIH R01 grant studying the epidemiology, pathology, radiologic features, and outcomes of myelin oligodendrocyte glycoprotein antibody associated disorder. His clinical expertise and research is focused on MOG-AD, aquaporin 4 antibody positive neuromyelitis optica spectrum disorder, and transverse myelitis. He directs teaching courses at the American Academy of Neurology on autoimmune encephalitis and myelitis. He works in the autoimmune and multiple sclerosis neurology clinics and the Neuroimmunology Laboratory at the Mayo Clinic. He also has an interest in perineoplastic neurologic disorders, autoimmune encephalitis, and the epidemiology of MOG-AD, NMOSD, and autoimmune encephalitis.
Dr. Chen, joining us, is a professor of ophthalmology and an associate professor of neurology at the Mayo Clinic in Rochester, Minnesota. He earned his medical and PhD degrees from the University of Virginia and subsequently completed his ophthalmology residency and neuro-ophthalmology fellowship training at the University of Iowa, where he was selected as head fellow. He joined the faculty at the Mayo Clinic in 2004, where he works closely with their Neuroimmunology department and has a special interest in optic neuritis, especially in the setting of the MOG-IgG associated disorder, MOG-AD. Dr. Chen specializes in the diagnosis, management, and treatment of optic neuritis. He works closely with Dr. Pittock and Flanagan, neuroimmunologists at the Mayo Clinic, to better describe the clinical manifestations of MOG-AD. He has expertise in optical coherence tomography and how it relates to optic neuritis, which will be pivotal in understanding the tools as a biomarker of the MOG-AD optic neuritis outcomes and disease progression. In conjunction with the Neuroimmunology Laboratory, he aims to identify other biomarkers of autoimmune vision loss. Welcome, Dr. Flanagan and Dr. Chen. We are thrilled to have you here with us today.
Thanks very much for the opportunity.
Yes, and I am also happy to start our first question here. We're going to jump right in and really take a deep dive into diagnosing MOG. So can you tell us a little bit about the recent collaborative study with Dr. Elia Secchi on the positive predictive value of MOG antibody testing and what this means for diagnosis, especially for those who are considered to have MS-like symptoms?
Yes, so thanks again for the opportunity to talk today. So yeah, this is a study that we did because we recognize that some patients who have low positive MOG antibodies can have other disorders. So what we found in the study is that some patients who have MS can have a very low level of MOG antibodies, and sometimes that leads to confusion about the diagnosis. And what we found is that patients who have a very high titer of MOG antibodies, which in our laboratory is 1 in 100 or 1 in 1,000 or greater, the vast majority of those do have the MOG antibody associated disorder, but we do find at low levels that some patients can have other disorders. So we wanted to raise that as a red flag for doctors, because MS is a good bit more common than MOG-AD, and that can lead to, if you keep testing all those patients, that can lead to false positives. We all kind of are immunologists in the setting of COVID, and we know that false positives can sometimes occur, and we sometimes see that in patients with MS. So we try to make sure that people weigh up all of the imaging and clinical findings and ensure that it's pretty typical for MOG and that it doesn't look like MS, because we don't want to diagnose those patients who have a false positive with MOG-AD.
Yeah, the assay itself is actually quite good. It's still got a specificity of 98%. So it's very specific. It's a lot better than an ANA test looking for lupus. But it's those lower titers, and especially if you're testing the wrong patient population, that's where you're going to get more false positives in there. And obviously that really changes management. So it's pretty important.
And I think for patients out there, it's just something that if they find that they have a low titer, they check in with their neurologist and they say, are we sure this is MOG? And a lot of times the MRI and the spinal fluid and the other findings can really help you discriminate that. So most neurologists will be able to tease that out, but it just would raise a little bit of a flag. It's it is an excellent test, and the vast majority of people with the MOG antibody do have the disease, but we just sometimes see a low level in the other patients for whatever reason. Yeah.
Can you tell us a little bit about the quality of the various MOG antibody testing available in the US versus the UK, and what that means for a person going through a diagnosis?
Yeah, I think the first thing to mention is that we use a technique called a cell-based assay. And this is a very reliable technique, and there's a few different types. There are live and inactivated cell-based assays, and these are utilized in Europe and around the world. And we've done studies with other groups in Europe, and we found that our assays are actually all very similar and all work very well. So the cell-based assay is the way to go. We have found that the live cell-based assay may be slightly better in one study than the other cell-based assay, but I think most of the cell-based assays out there are very good tests. And once a patient is tested with that, previously, back 20 years ago, there was studies that looked at other techniques that weren't using the cell-based assay that caused some confusion, and it looked like they might be markers of MS. And we now have this cell-based assay that's a really good test that helps us diagnose the condition. And I think it's very reliable across the world.
Thank you. That's a wonderful answer. Really a lot of good information there. So why is it that sometimes when someone has a relapse and their MRI comes back negative? And for these people, would you still treat them?
That's a good question, because it can sometimes happen. The majority of the relapses in MOG-AD it's typically going to be optic neuritis. And despite advances in MRI, optic neuritis still remains a clinical diagnosis. MRI overall is very sensitive for optic neuritis, but it can sometimes depend on timing and treatment. I know I've seen a patient who had signs of an optic neuritis, and they got an MRI within a day of the symptom, and it was actually negative. I reviewed it myself, but I was pretty convinced it was optic neuritis. We repeated the MRI when I saw him 7 days later, and it showed profound enhancement of the optic nerve. So sometimes, maybe the timing might matter. Maybe treatments with plasma exchange, IV steroids can matter. So, the MRI is very helpful because it provides objective evidence of an attack, either optic neuritis, myelitis, or ADEM. But if it really clinically fits, it's the clinical picture that matters. That's going to trump all. So with optic neuritis, you can have the pain with eye movements, the new decreased vision, a relative afferent pupillary defect where the pupil doesn't respond to light quite as well as the other eye. Maybe OCT will show thickening of the retinal nerve fiber layer. Those are all features of optic neuritis that are a true relapse. And, that's going to trump things. It's still a clinical diagnosis. The MRI is really nice. It's typically with MOG, it's abnormal, but there are rare times when it's not. And we're going to treat them if they have a clinical relapse.
And maybe I'll just mention a point that sometimes the doctors can order the wrong MRI. So for example, with an optic neuritis, you really want to do an MRI of the orbits with a special technique called fat suppression that makes it very clear if there's inflammation in the optic nerve. And sometimes that leads, if the doctor doesn't order the right MRI of the orbits, that can lead to missing the optic neuritis. I think also if you do have a completely normal MRI, then it's something that your physician might want to make sure that they're not dealing with a low positive, false positive. So that should always be in the back of the mind if the MRIs are completely normal. Because as Dr. Chen mentioned, if you order the right MRI, the vast majority of times it will be abnormal.
Why does the severity of MOG depend upon each individual person? Some people may have a lot of relapses with little disability, and there's others, such as myself, that may have 1 or 2 relapses, which with a greater disability.
That's a very good question too. All these demyelinating diseases, whether it's MOG, NMO, MS, they are all very different for each individual. We tend to think of NMO having more severe attacks with worse recovery, where MOG-AD patients tend to have better recovery. But this is kind of on average as a group. There's some NMO patients with excellent recovery. There's some MOG-AD patients with poor recovery. With MOG-AD, a lot of the disability does tend to happen with that first attack. And it may be because when you have the diagnosis, the subsequent attacks tend to be treated earlier, quicker, because these MOG-AD attacks, they tend to be very steroid responsive. And that may play into why some patients can have multiple attacks and not really accrue that much more disability. They may be just getting treated earlier, whereas that first attack, we don't know what the diagnosis is. It often leads to a pretty long delay in treatment because that's the first attack, often in a perfectly healthy individual before that attack. But every patient really is different. And we don't know why that is between all demyelinating disease conditions.
And I think that that's part of the reason we're trying to research the condition and learn, what is different about these people and how can we better help patients who present with a bad episode of vision loss so we can prevent, permanent damage. So I think what we really appreciate is, we have so many patients out there who are interested in being involved in research so we can help answer questions that can really help the community of MOG patients do better. So I think that's a great appreciation that we have for patients who give their time, who give their samples to try and help us learn more about that.
Well, we certainly are those people. So yeah, I appreciate that answer. It's a big question in everyone's mind. And, I want to back up just a little bit to a question about, false positives. So then do low titers have a risk of being false positives? And is there a known level that you've determined or you might know of which this occurs?
Yeah, I think, in our laboratory, we measure the low level is 20 or 40, 1:20 or 1:40. And a level of greater than 1:1,000 was really a strong cutoff for 100% of those cases in this study, had true MOG-AD. And most of the false positives were in the 20, 40, and a few at the 100 level. So, so really the lower titers, but sometimes the assays that are available out there don't report a titer. So it's hard for patients to know if they just get a result as a positive or negative, then it can be more difficult. But it's up to the neurologist to kind of put everything together and make sure everything fits. And neurologists are usually pretty good at doing that. So.
We have a community question.
If you have tested low with a titer that is considered a false positive, but then continue to test at the same level in subsequent tests, does that change the result to indicate a true positive? And can there be a false negative?
So I can start off with this and John can jump in if he wishes. So I think, if the clinical syndrome doesn't match, so say if a patient has a brain lesion that looks like a tumor, and it's not responding to steroids and everything looks unusual, then even if the antibody is persistently positive, we would still be concerned that that's just a secondary false positive. The MOG itself is kind of sticky. So the assay tends to give more false positives than some of the other testing. You can have sometimes a false negative. For example, there's a procedure that some patients may have underwent called plasma exchange, where we remove all the antibodies from the body. And if you test immediately after you've removed all the antibodies in the body, then the test will be negative. So that can result in a negative. And then sometimes over time, the antibodies kind of tend to go away and diminish, and that can result in a negative result too. And a lot of times those patients are doing better and they may not be having relapses at that point, and the antibody may just go to an undetectable level.
And then, it's also possible that some patients could get a false negative in that they have MOG-AD and the assay just maybe doesn't pick it up. And there's a lot of work right now looking at lumbar punctures or spinal taps to actually look at the fluid that circulates around the brain to see if that may be a marker where we can pick up some patients that look like MOG-AD, but were negative in the blood. But that's certainly some research that's ongoing.
Excellent point, Chen. Yeah, that's good.
Yeah. Hey, Dr. Flanagan, could you elaborate on what you meant by sticky? MOG-AD is sticky?
Well, it's a glycoprotein, myelin oligodendrocyte glycoprotein, and so we tend to think of it as being a bit more sticky than some of the other assays. Another disease that's quite similar that many people will be familiar with is the Neuromyelitis Optica, and that the biomarker for that is a water channel, which doesn't tend to be as sticky. So what we think is that it's just a little bit more sticky, and for some reason patients with MS or some other disorders may develop antibodies at a low level from their ongoing disease in the myelin, but that may happen. So we don't know for sure the exact reasons, but we think that that's probably part of the reason we see a bit more false positivity with the MOG than we do with the aquaporin 4 antibodies.
Thank you for clarifying that. So our next question, if a neurologist is unsure between a MOG or an MS diagnosis, what should they do?
Well, I think that could be a time, if it's a community neurologist, they don't have much experience, where they maybe reach out, they could refer the patient to an expert center. There's many experts, who see MS patients all the time, who would have a good sense for what MS is or what MOG is. And there's many experts throughout the country who, could see such patients and would be able to distinguish. There are some things on the spinal fluid, for example, the oligoclonal bands is a marker of MS. We see that in about 90% of MS patients. We see it only in about 10% of MOG patients. So that's another helpful discriminator. And then the way the MRI looks, MS has a certain pattern and it looks a bit different. And the lesions over time with MS tend to leave a scar. That's why it's termed multiple sclerosis. With MOG antibodies, the areas of abnormality on the brain MRI, oftentimes they disappear completely and resolve completely. And that's why we often see with many MOG patients, they tend to recover quite well from the episodes.
What tools do medical professionals use to diagnose MOG, and is it sometimes difficult to diagnose?
So the good part is we do have the MOG antibody assay, and it's a good assay, 98% specific. For these borderline cases, as Dr. Flanagan mentioned, there are ways to differentiate MOG from MS, from NMO, like the MRI. With optic neuritis being the most common manifestation of MOG-AD, the optic neuritis even has a certain phenotype that's a little bit different. It tends to have more optic disc edema, tends to be very steroid responsive. On the MRI, the optic nerve tends to be very inflamed, so much that it actually spills outside the optic nerve and actually involves the orbital fat. So there's actual clinical features that can kind of help swing you one way or the other. Dr. Flanagan mentioned the spinal fluid MRI characteristics. So, it's not any single test in isolation. Obviously, the MOG assay is going to help, and then the clinical phenotype will kind of be the tiebreaker.
Thank you for that. I'd like to move on and go past diagnosis a little bit and really take a good look at what the titers mean, for testing. The first question there is just what is the current thinking on what MOG titer levels mean as far as the prediction of relapse or your risk of relapse? And are there really any known levels of risk, percentages or whatever based on a patient's titer level?
Yeah, I think like John mentioned earlier, every patient is kind of different, but what we've seen on an overall level is that the patients with the very high titers are a bit more likely to develop a relapse. So those patients with a higher titer at the onset may be more likely, and that in our lab would be greater than or equal to 1:1,000 or 1:10,000. That would be very high level. And then what we see is also that those that have persistent antibody positivity, where the titers remain persistently positive, if you retest them at 6 months or 1 year, then those patients are more likely to relapse. But this is something that we're kind of learning as we go. And at the moment here at Mayo Clinic, one of the studies that was mentioned was an NIH grant, and part of that is to study and collect samples over time from patients to see if we can follow the antibody and see what happens. Does the antibody go away? Does it go up? And what's the risk? Because it's really nice if you can follow the patients from the start of their disease forward, and that's something we're trying to collect right now. And we appreciate many of our patients out there who have been willing to draw repeated samples so we can learn, and then this information can be applied to patients in the future.
Can people with a negative titer level relapse?
That's a good question as well. I tend to tell my patients with MOG-AD that about 50% of patients will relapse, about 50% won't. And the majority of patients, probably around 75%, actually stay persistently positive, and about 25 will become seronegative. And then if you become seronegative, there's probably about a 10% chance of relapse. So the answer is yes, it can, but if you do become negative, the chances are probably less likely. So we do tend to check MOG antibody titers typically about 6 months after disease, and then yearly to see what happens. If they become negative, that's reassuring, but they're not completely out of the woods. And as Owen mentioned, as part of the NIH grant, collecting these samples over time, I think will tell us a lot more about exactly how these titers influence relapses and prediction.
Thank you. Really appreciate that answer. So I've heard that immunosuppressants and IVIG or subcutaneous IG can impact titer levels. Could you clarify which medicines impact these titer levels? And do you know or are you aware of a percentage of reduction that they typically do in the titer levels?
Well, I think any immunotherapy can influence the titers. I think the one that would probably influence it the most would be plasma exchange, where essentially you're taking your blood, washing out the blood with the serum from all the antibodies and giving the serum back without the antibodies. That probably reduces the titers the most out of anything. That's typically what we use for acute treatments. If you have a very severe attack that doesn't respond to steroids, then we go to something like plasma exchange. I think IVIG can also influence titers, and pretty much any immunotherapy, rituximab, Imuran, I think they all can to varying degrees. I don't know the exact percentages, but if you had to put the order in terms of one that would influence it the most, it'd probably plasma exchange.
Is there any reason to test titers periodically? And would you take a person off their preventative treatment to do so?
We are testing them periodically. We're checking, 6 months and then yearly. And I think that's going to provide some exciting information and hopefully some predictive value in terms of what's moving forward. But we're not taking patients off immunotherapy to test for this. I think it'll be helpful to look in the future to see how much these actually influence the titers, but we're certainly not changing management. If a patient truly needs some kind of treatment like IVIG because they've had many severe relapses, are accruing a significant disability, we wouldn't want to put them in a vulnerable situation just to check the titer at this point.
Okay, thank you. We actually have a community question here. Does a low or high titer predict the severity or longevity of the disorder?
I don't think we know fully yet about that. It's something we're interested in looking at, what the titer means in terms of your risk of relapse, because really with MOG, if you have one episode and you're never going to have another episode, we don't want to put you on a treatment that lowers your immune system for many years. So that's one of the major interests, but I don't think we know yet about, you know, the outcome in terms of, you know, a high titer. Does that mean you're destined to have more problems down the line? I think that requires more study. Yeah. John, I don't know if you have other thoughts. Or
No, I agree as well.
Yeah.
I mean, the titer right now is really helpful. And, you know, if you got a 1 to 1,000, 1 to 10,000, you know that's definitely MOG. You don't have to worry about a false positive there. I think that's something that we definitely know. But in terms of predicting severity, predicting relapse, that part's still a little up in the air.
What are the latest numbers for those who have MOG in the US and worldwide?
And what do the data trends show as far as age, gender, and race prevalence in the patients with MOG?
Yeah, that's an excellent question. And, you know, it's something that we don't really know for sure yet. It's something we're actually studying in our county here. And our provisional numbers suggest about a prevalence of about 4 per 100,000 or so. But the problem is that it's a new disease and people are only starting to recognize it now. So we're probably undercounting the cases, because as people will start to order the MOG antibody and confirm the diagnosis, we're going to pick up more cases. There is some differences though in the what we call the demographics or the gender frequency with MOG antibodies. It tends to be a bit more equal, so men and women can be more equally affected than we see with MS or we see with neuromyelitis optica, where women tend to be much more affected. And we haven't really seen a particular racial or ethnic variation. This seems to occur across all ethnicities, and it's been reported in all types of the world. In some parts of the world, it seems maybe a bit more common when compared to the aquaportin 4 positive NMOSD, but I think we need to do more study there. But we haven't really seen an ethnic difference, and that's a bit different to aquaportin 4 positive NMOSD, where we do see that African Americans, Afro-Caribbeans seem to be more predisposed to that disease.
Yeah, we also recently did an incidence study on optic neuritis using the Rochester Epidemiology Project. So here we took and looked at all the optic neuritis within the community, and we could actually see the relative percentages of various diseases. And 50% of optic neuritis was caused by MS, 5 to 6% were caused by MOG, 3% were NMO, and what's striking is still 30% were idiopathic. What that means is we looked at for every single disease we could do, and we still don't know them. There's still new biomarkers that need to be discovered. But it is good to know that probably, at least for optic neuritis, it was about 2 times as common as NMO. And in a predominantly Caucasian population, it's still much less frequent than MS.
Wow, that's an amazing statistic. I want to give you a community question that came up. We thought it was a really good question. So this person asks, how do you know if you're going to be monophasic or multiphasic? Do multiphasic patients share any characteristics in common? I don't know who wants to take that.
I can start with that. So I think that's it's difficult, and that's why after a first attack, we know that about half of people will go on to develop a relapse and half will not. So we don't know for sure which patients that will be. And that's why we tend to only treat people who have had 2 episodes. We treat the acute attack, but we only put them on preventative treatment after 2 episodes, with some exceptions where patients who have a severe episode, some of those patients will start them on treatments right away. But it's something we don't have a good handle on at the moment. And that's one of the things we really need to study, because it would be nice if we could treat people from the first episode if we knew that they were going to go on to develop a relapse. But at the moment, we don't know that. So we wait until they have a second episode, which is not ideal.
The good part is that if a patient does relapse with MOG, they know they have MOG. Let's say they had a single attack with good recovery. Again, we don't know if they're going to relapse or not. Obviously, I wish we had a crystal ball. But right now, at the time, we're limited. But the good part about MOG is if you know you have the disease, you're looking out for that relapse. So if you do have that relapse, usually we're able to treat them very early with steroids and can get very good recovery in those subsequent relapses. And then then we know they're going to be a relapsing kind of patient. Then we can put them on more chronic immunotherapy. But yeah, as Dr. Flanagan says, after a single attack with good recovery, unlike NMO, we're not going to put them on chronic immunotherapy because we'd be over-treating 50% of our patients. Some patients are not destined to relapse at all.
Are there any vitamins, supplements, or diets that have shown or anecdotally shown to reduce titer levels?
I'm not aware of anything that suggests diet, makes a difference. So I don't think, but I'm not sure it's been well studied either. So it's probably something we need to study in more detail. This has been looked at extensively in multiple sclerosis, and they haven't really found convincing data other than, the importance of vitamin D with multiple sclerosis, but otherwise haven't found much. But I think a lot of work to do in MOG to look into that further. But as of now, we don't have a particular regimen we recommend or vitamins we recommend.
Okay, thank you for that. That's a question that circles around the community a lot. I think at this point we want to move on to talk a little bit more about treating MOG. People have a lot of questions surrounding that, and there's a lot of confusion. So the first question is: are there cases where a monophasic MOG patient should be on preventive treatment, and if so, can they ever stop at some point?
Yeah, I think there are some patients who do have a severe episode where after their first episode, because it was so severe, and maybe if they lost vision in one eye and we're trying to protect the other eye, we do start a treatment to try and prevent that. Of course, we don't know at the moment if the treatments work because we haven't done any randomized controlled trials with placebo groups and that. But we do sometimes treat people if they have a very severe episode, particularly with poor recovery. That might be a situation. Unfortunately, we don't really know how long to treat patients for either. So, I think that's an open question, and we haven't really got a handle of that yet. We tend to treat for at least a few years, and then sometimes we monitor if they're having side effects, and we may consider a withdrawal of treatment down the line. I think it's safer to do that in the MOG antibody disease than in the aquaportin 4 positive NMOSD, because those patients tend to have more severe relapses and not recover as well. But I don't know, John, if you want to comment. Or
yeah, no, I completely agree. Every patient's actually different. We have a long discussion, based on the patient, how much damage they sustained, how much disability they're accruing, and it's a long discussion. In fact, our discussions on treatment for MOG is actually much longer than our treatments for NMO. If they've got NMO, it's actually a quicker one because everyone needs to be treated. There's no real debate. Whereas with MOG, there is a lot more, patient preference, and there's, a lot more discussions on, weighing the risks and benefits of chronic immunotherapy.
How long should someone stay on treatment if they've had multiple relapses? And at some point, would you take them off treatment?
I can take that one. Again, that's a difficult question. If they're having multiple relapses, we do tend to recommend treatment because we know that with each episode, even if they recover, mostly all the way, each episode can leave them with a little bit more disability. So we do like to try to prevent the attacks in those who are having multiple attacks. And then, we don't really know again about when it's safe to withdraw immunotherapy, particularly in those with multiple attacks. We would tend to treat them more in the medium term, at least for now. And then, I think what's going to happen the next many years is we're going to develop proven treatments for MOG, where we know that the treatment works, and then then we can make those decisions better about how long to treat and what's the safety profile of those medications. Because at the moment, we don't know how well these medications work. We just kind of take these treatments from other diseases that we know are immune mediated and hope that they are working, but we really need proven treatments. And I think that's what's going to come over the next many years. There are many drug companies who are interested in investing in this disease, and we are interested in partnering with them to try and develop a proven treatment. So I think there's going to be future treatments coming, which is great for our patients. And that will help us decide on duration and safety and that kind of thing.
Thank you. And I tell you, as a MOG patient on treatment, that would be a wonderful day when we could all get rid of our treatments. But for now, we hold tight. We've got a community question again. So this person asks, after stopping preventative and negative for MOG, how often should a patient be retested?
I know right now we're checking our patients once a year, and a lot of that's for research purposes, but I think clinically it could be helpful. So essentially, the patient was treated, no more attacks. Now they're seronegative. Now off treatment. That's a good question, but certainly I think a year from now would be a good reason to kind of recheck, see how things look.
Yeah.
But if they became positive, the question is, do you start treatment then, or you could potentially still leave them off if they didn't have an attack? So it may not matter that much, but it'd be interesting to see if they kind of jump back and forth between positive and negative.
MOG patients tend to be steroid dependent and responsive. Do we know why?
That's a good question. Not exactly, but it is a very helpful phenotype that will make you think about MOG. There is actually this, or it still exists, this diagnosis called CRION, chronic relapsing inflammatory optic neuropathy. Essentially, that was an optic neuritis that was not only steroid responsive, but steroid dependent. And we didn't know what it was, and we just lumped them all into CRION. And of course, now that we know MOG, we found that explains probably at least half of those idiopathic CRIONs. And then, I'm sure there's some other biomarkers out there that explain the rest. So it's something that we're certainly recognizing in these patients. I'm sure it has to do with the pathophysiology. It is probably just more of an inflammatory component with MOG, and that's why it responds more to steroids than with NMO. There's probably more astrocytic destruction, so it's less responsive. But it's certainly a phenotype. It makes you think. If you get one that's very steroid responsive, you want to think MOG. And fortunately, it does respond for the most part. So typically, patients recover pretty good from their attacks.
Thank you so much for your response on that, because I was originally diagnosed with CRION.
Oh, really?
Yes.
Yeah. It's an entity that we're still trying to chip away at to try and understand more. And again, there's still a few more biomarkers out there to discover.
Mm-hmm. Yeah, well, thank you for that. And my next question here is if Ocrevus and rituximab have been used to treat MOG-like MS symptoms. Is this the right option for patients whose doctor is not sure whether they have MS or MOG?
Yeah, I can potentially take that one. Yeah, I think that's actually a reasonable option. We know that those medications are very, very effective in multiple sclerosis. We think that they work partially in MOG, not perfectly, but seem to work partially. So that would be a good option if the doctor kind of is not sure if it's really on the MOG spectrum or more in the MS and the antibody is low. They're not sure if it's a false positive. That would kind of cover both disorders fairly well. So ocrelizumab or Ocrevus or rituximab are reasonable options in that situation, I would say.
Thank you. MOG patients tend to have a lot of relapses compared to aquaporin 4 and MS patients, but have better recovery. Does this affect treatment plans long term?
you want to take? Do you want me to take that, John?
Or do you want to take that one?
Sure. So it's interesting what we see with the way disability occurs with the MS. What we see is that most patients get the disability in the progressive phase of the disease. So that's many years after their initial diagnosis. They can have slow, gradual progression where they might require, not be able to walk the same distance that they used to, and then eventually require a cane or a walker or some assistance with walking. With the aquaporin 4 antibody, we tend to see severe attacks with incomplete recovery. So a patient might have one episode of myelitis and they, drag one leg. They might have a second episode, they require a cane. A third episode, they require a walker, and they tend to get the disability related to the attacks. With the MOG antibody, it tends to be a disability tends to occur mildly with each episode. So a patient might have one attack and they have some mild difficulty with vision loss, and then they accumulate a little bit each time. So it is important to prevent it, but the way the disability occurs seems to be different between the disorders. And I think the goal with the MOG is going to be trying to prevent the relapses, because we don't really see that progressive form of the disease that we see in MS. So in MS, one of the goals is to try and prevent that progression from happening or to slow that progression, but we don't really seem to see that progression with MOG. So it's more important about preventing attacks, which I think is where the treatments are going to come in the coming years.
All right, thank you for that question. We're going to go again to another community question. Is there a recommendation as to how long one should remain on treatment if there has been no relapse?
John, you can go ahead.
Yeah, that kind of goes back to the question of it's $1 million question. It's tough to know for sure. I think it depends on how severe the attacks were, how much disability there is. So essentially, they're blind in one eye, pretty compromised vision in the other eye. You can't really afford another attack. It could be blinding in both eyes, or if you already have significant problems with mobility, you can't have another attack. So those patients we probably would treat longer, we treat more aggressively. If the patient has had a few attacks but had pretty much almost complete recovery, no residual disability, those patients we might consider trying to back off over time and hoping they don't relapse. And of course, if they do, treat very aggressively early on to prevent further disability. But so I think it really kind of depends on how severe the disease is, how much disability the patient has.
So what is the best treatment for MOG-AD?
I said the prior question was $1 million question, but maybe this is the $1 million question. I wish we knew for sure. So right now we just have large retrospective data. As Dr. Flanagan mentioned, we essentially just take medications that have been used for other diseases and are applying them to MOG-AD. And what we know is MS medications, the traditional ones, don't work. So that we know for sure. We're not going to put a patient on Rebif or Avonex. It's just not going to be effective. Traditionally, we have used the medications that we use for NMO. And so that'll be rituximab, azathioprine, mycophenolate. Those are some of the old traditional medications. And then some of the newer medications, we're not sure if they're going to be effective, but they probably will have some effect in our patients with MOG-AD. And then interestingly, when we looked at all of our data with a bunch of collaborators around the US and some around the world, we found that IVIG could potentially be pretty effective in reducing relapses in MOG. And so it's something that we certainly offer at times if a patient has very severe disease, relapse in disease, that's breaking through rituximab or azathioprine. Sometimes we'll switch them over to IVIG. And we've certainly had some good success with that. Unfortunately, the numbers are small enough that we can't know for sure. But there's certainly evidence around the world that IVIG could potentially be very effective.
And I think sorry, go ahead, John.
Oh, go ahead.
Yeah, I was just going to say that IVIG is a nice option in that it doesn't lower your immune system like the other medications. So with COVID and other concerns about infection and long-term side effects from lower immune system, IVIG has a benefit in that way, although it is quite expensive, and sometimes insurance companies are reluctant to cover it. But sorry to interrupt.
Oh, absolutely. I was just about to mention those things. The cost is tough. Insurance companies are tough. But certainly in patients with very severe relapsing disease, sometimes we'll try that. And we've certainly had some good success in some patients.
Yeah, thank you for that. That's certainly, I'm on the subcutaneous version of that, and it's certainly something that's made me feel much better. So I'd love to have more research done in that arena later on. I think we've had a lot of million-dollar questions, and so I'm just going to, go out and give you a $5 million question, which is, why does each individual respond differently to preventative treatments like Rituxan or IVIG? Do you know?
It's really tough. I think it's very similar to, why do some patients with MOG have more severe disease? If there was one treatment that worked for every patient, there'd be one treatment. And if you look at all the various diseases that we treat, there's multiple options, and it's because it's hard to predict. I think in the future, we will find some medications that are going to be better overall. Maybe IVIG will be better than rituximab, still to be proven in randomized trials. But there's some patients that respond great or appear to respond great to rituximab. So every patient's different. We typically just kind of step through medications. If they relapse through one, switch over to the other. I think the immune system is just much more complicated than we think. It'd be nice if it's just Titer, you got a 1 to 1,000, then yes, you're going to need this medication. If you're 1 to 100, you need this medication. But it's unfortunately not that simple. It's much more complicated in terms of how the immune system attacks the brain and the optic nerves.
Thank you. Community question here. If after 2 vaccinations, a MOG-positive patient on Rituxan has a negative COVID-19 spike protein test, should they get a 3rd vaccine? And what's the current thinking on this?
That's an excellent question. I think this is a worry with some of the medications that reduce your B cells that produce your antibodies, that the vaccination response might not be quite as good. They are doing some studies in transplant patients and other patients who are on these types of immune lowering medication, and there has been some preliminary work that suggests that a 3rd booster dose may be beneficial, but it's not really been a recommendation from the CDC or from our group here at Mayo Clinic just yet. But I'm hoping the data looks encouraging. I think it's something we need to study a little bit more, but I'm hoping that down the line that might be something we can offer to our patients who have MOG-AD or any of our other diseases where we use these treatments, like multiple sclerosis or neuromyelitis optica spectrum disorder.
I know a question that comes up often with our patients is, if they have MOG-AD, do they get the vaccine? Do they get the COVID vaccine? And for the most part, we are recommending it, even if they are on immunotherapy. We are recommending these obviously weighing risks and benefits, but overall, we think the benefit outweighs the risks.
And it's not all just based on the spike antibody. There's T cell responses and other things that are likely. So yeah, we certainly strongly recommend COVID-19 vaccination for all our patients, and we want to try and protect them as best as we can. And I'm certain they do get some protection, but it may be that additional boosters may be helpful. So I'm hoping that the data continues to show that, and maybe that can be something we can recommend in the near future.
Yeah, thank you for that. I know a lot of people, including myself, went in for that vaccine with a little bit of dread, and I'm sure most of us did do well. So I want to move on to our next section. This talks about the future of Mog Research, especially at the Mayo Clinic. So I just wanted to know what significant discoveries in the world of MOG-AD have been made in the last 5 years, and what is currently happening, especially at the Mayo Clinic, in terms of new research or finding a cure.
Well, if we go back 5 years, actually, it's a lot has been in 5 years, because 5 years ago, we barely knew what MOG was. And so in 5 years, we've definitively determined that MOG-AD is a separate entity from NMO and MS. We've characterize its phenotype. And now, obviously, we're trying to figure out the best treatments for it, finding out that perhaps IVIG is better than some of these other medications. And so if we go back 5 years, everything we know about MOG is essentially within 5 years. So we've made huge headways in the past 5 years. At the Mayo Clinic, we really have a passion for MOG. We love seeing patients with this and hearing about their story and trying to provide the best guidance that we can. I think there's a lot to still be learned about the condition. Again, still trying to figure out the best treatments. And eventually that will be future randomized clinical trials with some of these medications to actually prove that these medications work in preventing attacks. We've talked about how steroid responsive MOG attacks can be. So we're looking at immediate steroids to see if we can prevent that damage. Essentially, we do what's essentially steroids in the pocket, prescribing these huge doses of oral prednisone that if they develop the eye pain, the vision starts to drop on a Friday at 9 o'clock, they don't have to wait till Monday or Tuesday the next week. Essentially, they can just take the medication and try and rescue that vision loss or whatever attack that's happening. And so we hope that this kind of steroids in the pocket is going to help. As a neuro-ophthalmologist, of course, I've got a huge passion on the optic nerve. So we're doing a lot of OCT angiography work to try and predict, to use it to help differentiate optic neuritis from other forms, predict outcomes, and try and understand some of the pathophysiology behind it. Owen, thoughts on this?
Yeah, I can make some thoughts. I think I agree with Dr. Chen. I think the last 5 years we've made great strides. Before 5 years ago, we didn't have any MOG commercially available assays in the USA. Now they're available through multiple laboratories, including ours at the Mayo Clinic, but including many others, which makes the diagnosis easier to come by, that physicians can order the test. We have been, we're always talking about MOG at our meetings. I know Dr. Chen at the ophthalmology meetings and myself at the neurology meetings, trying to educate doctors about making the diagnosis. And a lot of the work we've done is on, how do patients present? What does their MRI look like? How is it different from MS and NMOSD? And one thing I have an interest in is how the lesions evolve. With MS, we know that they leave scars in the brain, and I think that contributes to some of that long-term damage that we see in MS. While with MOG antibody disease, the inflammation and the areas of abnormality on the brain MRI tend to really, a lot of the times, resolve almost completely, and that's quite different, and that's something that maybe we can learn more about and also help our MS patients. Another thing we're looking at, which many questions were about the assays, about the antibody titer and following that over time. If the antibodies start to rise, could we predict a relapse? I think, what does the antibody level mean for the patient's outcome for the type of treatment? But I think the next 5 years are going to be about treatment of MOG. I think we are going to be partnering with drug companies to try and develop a proven treatment to prevent attacks that is safe and effective. And that's the number one priority for many of us in the field, I think, is to get a treatment out there that is proven to work, that can help prevent attacks and help prevent disability in patients with MOG, and essentially, quieten the disease down towards curing the disease. So I think that's something that we're all very interested in, but that will require partnership with pharmaceutical companies to try and really bring that to the forefront so we can, prove that there are treatments that work in MOG.
This next question truly hits home for me. There have been a few studies on remyelination. We were just wondering, what has the progress been in regards to remyelination with demyelinating conditions as well as MOG? And as well as another part to that, will you ever be able to repair the optic nerve?
I think that MOG will be a very good candidate for remyelination. This with MOG, they do tend to recover, and I think a lot of that is from remyelination. But there are some patients that can have these attacks where it doesn't, and so if we can improve upon that remyelination, I think that can lead to better outcomes. I think one of the most commonly used animal models for demyelinating disease is actually using MOG to induce inflammation in a mouse. And a lot of the research on remyelination is actually using this model. And so with these treatments in these mice that are effective, I think it's going to translate very well to humans with MOG. You know, if you look at just optic neuritis overall, there's a lot of things that have been tried, like clemastine, which is an antihistamine. There's estrogen receptor ligands. There's all sorts of medications that could potentially improve remyelination. It hasn't been studied particularly in MOG yet, but again, I think MOG would be a great disease candidate for these treatments. Yep. And that second part, in terms of regenerating the optic nerve, that is something obviously we're all striving to do. So I think the future for that will be stem cells. Right now, we're at a point where we can actually take skin and grow an optic nerve in a dish. The problem is we don't know how to make that optic nerve go from the eye all the way to the middle of the brain, which is its first connection. So we're getting there. You know, typically, if we can get it working in a dish, it takes about 10 years to get it working in an animal, and about 10 years from an animal to get it working in humans. So I think we're within that 10 to 20-year range, but it could be sooner. You know, it could be a lot sooner. But I think there's a lot of hope in regenerating the optic nerve. And I'm very excited to see the progress that's been made over the past decade or so.
Yeah, and I agree with John, and I think we can learn from the other fields. You know, there's lots of studies going on in MS with regard to remyelination therapies that could be applicable to MOG antibody disease. So I think, you know, there's going to be multiple avenues, and then there will be crossover of treatments between these different diseases.
You know, you certainly would see a lot of very happy people if that happens someday. So I want to ask a question about gene editing. Is MOG a condition that could be addressed using gene editing?
Yeah, I can address that. I don't think MOG is one of the diseases that the gene editing is going to work well for. You know, that really works best for some of those genetic conditions like spinal muscular atrophy, where there's a single gene problem that's the cause of the disease, and you can edit that gene and make it work better. But at the moment, we don't actually find that many people have, you know, that there's familial clusters of MOG, or that it tends to cluster in families. So we don't think that the genetics is quite as important as some other neurologic diseases where this has been a real breakthrough. So I'm not sure that that's going to be as much of a great option for patients.
Community question. We have a community question.
Which COVID vaccine is effective and safer for MOG and still taking immunosuppressants like rituximab?
Well, I can start with that. You know, I think the mRNA category of vaccinations seem to be the most effective. That would be the Pfizer and the Moderna vaccination. The Johnson & Johnson also works very well, but is, you know, slightly less effective. The AstraZeneca is similarly slightly less effective. So, I think, you know, if there's a choice, you know, I recommend the mRNA vaccinations for patients, but it may depend on what region of the world they're in. You know, in the USA, you may have the option, but in other countries, you know, they have limited supply and don't have the option.
Well, thank you. Well, I sadly have to say that our time together is coming to a close. It was wonderful, wonderful information. I think everybody's going to be really thrilled about the recording if they've missed it. We'd like to thank Dr. Flanagan and Dr. Chen for their time and commitment to the MOG-AD community. If you'd like to check out the page on our website dedicated to the work that is being done for MOG-AD on the Mayo Clinic, please go to our website at mogproject.org/resources/from our medical advisory board/Mayo Clinic. We also have a special link to a foundation set up at the Mayo Clinic by our Chief Media Officer, Jim Broutman. Here you can donate directly to support the great work that the doctors do there at the Mayo in the Neuroimmunology Laboratory. You can find that also on that page as well as our donate page on our website.
We want to say thank you so much to our community and for all of the community questions that came through. And please don't forget to check out our MOG blog, as all unanswered questions will be placed there from this MOGcast.
Yeah, thanks everybody, and have a great rest of the afternoon.
Yeah, thanks to all the patients out there. We really appreciate their support and their willingness to participate in research so we can learn more about this disease. We really appreciate it and wish them all the best. Yeah.
Thank you.
Absolutely.
Thank you,
And
Doctor.
Thank you.
yes,
Thank
thank
you.
you to the MOG project as well.
Yeah,
Thank you,
of course. Yeah.
Okay, great, everybody. Have a great rest of the afternoon. Take care.
Thanks.
Bye.